we're going to talk about the FDA making another move with regards to black box labeling and specifically outdated hormone warnings on women's hormone supplementation.
Before we dive in, we have a quick but important update regarding the topic we're about to discuss, hormone replacement therapy, or HRT. When we recorded this segment, the big news was the unanimous recommendation by the FDA's advisory board to remove the severe black box warnings from all HRT products. But before we could get the segment edited and out to you, the FDA has actually gone a step further. They've followed through with that recommendation. On November 10th, FDA Commissioner Dr. Marty McCary announced that black box warnings are officially being removed. This is a massive win for patients and for common sense. We've decided to run the pre-recorded segment because it provides crucial context and a deeper understanding of exactly why the advisory board made this change in the first place. Think of it as a behind the scenes of this major regulatory change. So stick with us as we explain the history behind the black box and why the science finally prevailed here.
Some doctors say women's health is being harmed because they're not being informed about the latest safety studies on hormones. They say the black box warnings are outdated and need to be removed by the FDA. And recently, a panel with the FDA commissioner unanimously recommended that it be removed. Quote, "It's also been found to reduce cognitive decline by up to 64% and, in one study, reduces the risk of Alzheimer's by 35%, unquote, said the FDA Commissioner Dr. Marty McCary. At a recent FDA panel, the commissioner and expert doctors in hormone replacement after menopause gathered to dispel myths that all HRT is dangerous. That is definitely a myth. They focused on both local vaginal creams and full body hormones. Quote, "There's a black box warning even though the North American Menopause Society and the American College of OBGYNs has called for removing it. We discovered there is a black box warning on systemic estrogen, even though no clinical trial has ever found an association between hormone replacement therapy and an increase in breast cancer mortality," he continued. Quote, "I pored over the research only to find something earth-shattering that history got it wrong when it comes to menopausal hormone therapy," said Dr. Heather Hirsch, an internal medicine physician with Health by Heather Hirsch. Quote, "Testosterone is the most abundant gonadal hormone in the body, and women deserve access. The science is solid, and the need is undeniable. Picture 108 million women, energized, focused, and ambitious, not in spite of their age, but because they are supported through it," unquote, said board-certified urologist Dr. Kelly Casperson. This sounds like this is more than just one hormone. They're talking about all of there's three major hormones, right? For women, estrogen, progesterone, and testosterone, if my rudimentary health knowledge serves me right.
Yes.
Okay. So it sounds like they're talking about all of this stuff. And this article goes on, lists a whole bunch of other things. We'll link it down below if you're curious. What's going on?
So I think the most important thing to understand kind of from the jump is that in around 2003, there was a study being done at the Women's Health Initiative, very large in the 90s, that led to a 2003 black box warning on hormones. So I think some of the nuance that's critical here
On all hormones.
on all hormones. And
Wow.
Yes. So they looked, the data they found is solid. Okay.
Right.
Definitely. But I think so then you have to look at what was actually studied on the solid data that was gained from studying that specific thing, hormone, and then what it led to for the other hormones. So essentially what happened is the patients, the women were given Premarin or Prempro. Okay. So they were giving a synthetic form at 0.625 milligrams of the estrogen that has shown and showed in the study to increase risk of coronary heart disease, stroke, venous thromboembolism, and invasive breast cancer. The only benefits they found were some reduction in hip fractures. So again, the data, very good. But it was an oral form of estrogen, not bioidentical. Both things are critical in this case. Mainly the oral component even over the kind of the bioidentical part that's critical. So what the FDA does is when medications are in that class, they essentially apply the same black box warnings across the class. And that's typically beneficial. I mean, knowing from pharmacy background, when medications work in the same way, they're in the same class, they have this, there are nuances, but they generally function in the body the same way. So if you found that for sure there's an issue with one maybe specific drug in a class, you can apply it to the others. In this case, though, the broadness of what this swept was, the issue largely is that this is an oral hormone, which goes through first pass metabolism, okay, and then increases clotting factors, which led to increased stroke risk, increased venous thromboembolism, increased coronary heart disease. So that's kind of the main thing. But then it got applied to transdermal estrogens, which are estradiol, which are bioidentical for whatever, benefit or lack thereof that you want to apply to that is fine. But the key thing here is that it's transdermal. So it was applied to that. And even more problematically, it then was also applied to local. So essentially vaginal estrogen creams that are used for local symptoms only, that have very limited and insignificant amounts of systemic body-wide effect.
Right. It's going straight into the bloodstream.
To everything.
Wow.
So it really, I remember even my dad telling me that kind of these medications, this Premarin, Prempro, they were dispensed like crazy in the 90s. So maybe there was a little bit of some over prescribing, and then this study kind of pushed things the other way, that, any hormone has this black box. You get a prescription for transdermal, Vivel dots, or estradiol transdermal, or micronized progesterone pill, which I know I said oral is not good, and progesterone, It's fine. It's about the clotting factors that increase when an oral estrogen is taken.
Okay.
So then it's applied to all of these products. It's lumped in. The side effects, this is not, there's some minor issues. This was stroke and clotting. And so right there, the hammer's been dropped, but again, you're applying it to what's in the most broad sense the same class, but is a completely different mechanism of delivery, which understanding how they work was unfortunate, because there definitely was some lack of prescribing, lack of, potential innovation around these. And it led to, maybe a lot of women, maybe in the 90s, the trigger was pulled too quickly on let's get you on some hormones. And maybe in the 2000s, it was way too slow.
Right.
And you've got to have these major, major symptoms. Your quality of life has to be so dramatically affected, or else we're not, giving you a hormone.
Not even going to consider it. Yeah. That's my understanding, is that it has been rough for a lot of women that didn't need to necessarily have these negative side effects of menopause. So this is just an FDA panel. This is not an official removal of the warning yet, but it has been unanimously recommended by the advisory panel, with the FDA commissioner also voting for it. So presumably this is coming down the pike pretty soon, right?
Seems like it. Again, I think that the WHI study was good, and I think those black box warnings should be added to Premarin and Prempro, but the expanse that it went to is the problem.
Yeah.
That's really the issue here. And so I think, what's then important is to say, well, okay, I can't go on the Premarin or Prempro because that's not real good for me relatively, and not to downplay how bad it is to have hot flashes and night sweats. But, when you're comparing risk of cardiovascular disease with something, you shift the scales a little bit. So the assumption would be is, my goodness, well, the transdermal estrogen, the micronized progesterone oral, they don't work that well. So you've got to compare that this isn't working that well, and the only ones that really work, but it's not the case. Studies show that for specifically vasomotor symptoms, so the night sweats and the hot flashes, that the effectiveness of transdermal estradiol was similar to any form of oral estradiol, including the Premarin and Prempros.
Wow.
So the effectiveness is the same. The risk of venous thromboembolism, 0 increased risk when compared a transdermal to an oral estrogen. Coagulation factors, inflammatory factors, no increased risk when you're doing the transdermal. Bone protection, similar. So we did find, the one positive of the Premarin and the PremPro in the WHI study. The one benefit they found was related to bone health. Systemic estradiol still increases bone density and reduces fracture risk while in use.
So that is one of the big things. We've talked about osteoporosis and osteopenia quite a bit. That seems like that alone should be a major consideration for whether or not to even consider this, that we don't want women having low bone density. And this is one of the primary drivers of that initially, isn't it?
Yes. And I think, it's still important to understand we're still talking about hormones. There's still more studies to be done. So this is not, so you can just use this stuff with impunity and there's no issue.
Sure.
From a stroke and arterial event, there's a little bit of controversy there somewhat compared to each other. The VTE risk is significantly lower, but you still would want to avoid it in high-risk people. So if you have an issue with clotting, a history of clotting, then you can err more on the side of caution, even with a transdermal, in any type of high-risk situation like that. But again, if there's no high-risk situation there and you're having significant symptoms, I still think it's something reasonable to do to try to get some relief.
Why would anybody be considering the oral over the transdermal at this point? It seems like there's not a bunch of reasons to suggest even considering it at that. And what am I missing?
From a standpoint of hot flashes, vasomotor symptoms, there's no real reason to. There are some other cycling issues, some more kind of, we'll call them maybe more intense issues that can still be addressed. I mean, you're kind of using a hammer with the Premarins, et cetera. So I don't want to say there's no use for them, but when you're looking at kind of more of a quality of life, vasomotor symptoms, hot flashes, those kind of things, there is no real reason.
Okay, so the oral is kind of the big guns of this environment that they really come into play when it's a really serious situation that you need a bigger supplement.
And sometimes, what has happened is, especially maybe you were on this in the 90s and you've made the decision, hey, I'm not coming off of it. And they tried to switch me to the transdermal. It didn't work. Well, there's definitely some dose increasing. Again, like you said, that's a good word. The Premarins and PremPros are the hammer. So if you were maybe on those with effect and then you get changed to a transdermal, it can definitely take some time to get regulated and to still get some relief. So it doesn't mean that because again, when done, in a randomized control, the effectiveness is the same. But when you come off of the hammer and you add in the transdermal, that's where there can be a gap. Because again, there may be people listening and say, hey, this is the only one that works for me. And at this given time and for the next month or two, you're correct. But over time, given the lack of risk comparatively with a transdermal, you're in a much better situation.
That makes all the sense in the world. This makes me excited. I hope that more folks are able to get the help they need. There is no sense in living with horrible side effects like that if you don't have to have them. Anything else we're missing?
I think, and this is to emphasize that the local estrogens are, I hate to say anything black and white, non-issue. Okay. It's maybe a slight issue, still some weighing of the scales of benefit with transdermal, but the local is there's just really no systemic absorption of it. So to not be using it for the symptoms that are local to the area is just, it's unfortunate because you have probably some women that are getting, oh yeah, my doctor said it's fine, but then, my pharmacist printed me out this big sheet with this big warning and I'm not touching it. My grandma had to and that, I think, for the local, I can be a little more aggressive and say that one just needs to go.
I have a family member that was dealing with all of the side effects, and she was very hesitant to go anywhere near hormone replacement therapy for that very reason. So that's really good to hear. I'm really excited about that.